there were several questions about definitions. The definitions of Parkinson's versus Parkinsonism versus supranuclear palsy. So if you could, either one of you, maybe just give a general description of the definitions with all of these different syndromes and what that looks like, and how to break that down for people. Great.
Parkinsonism is the broad category. Anything that looks like Parkinson's disease could be appropriately characterized as Parkinsonism, but within that domain are a number of things that look like it but are not that. And so common ones would be, for example, when you take certain medications that are for schizophrenia or augmentation of depression, like Abilify, for example, that can block dopamine receptors and cause Parkinsonism. If you are over 80 some years of age and you slow down and you walk with a shuffling gait and you're kind of stooped, that could be simply age-related Parkinsonism. And then the three categories that are in the neurodegenerative disease category are obviously Parkinson's disease is one that's by far the most common. Progressive supranuclear palsy. There are 7 different variants of that. And then finally, multiple system atrophy. And you can put into that category cortical basal syndrome, which actually sort of looks like it because it's an asymmetric disorder with rigidity. But the clue to that would be apraxia. What is apraxia, you might ask? You would ask me that?
Go ahead.
Okay.
Elaborate.
Yeah. Well, you probably noticed on the neurologic exam on that videotape, this was one of the things that the Parkinson patient was asked to do. People that have other disorders, they might just do it with a slowed kind of response to that. In Parkinson's disease, the amplitude is dampened, so like parallel to what happens with stride length and arm swing and so on. But in people that have apraxia, when you say do this, they do, I don't know if you can see that, but the problem has to do with this area of the brain that, oh yeah, I'm sorry. I'm getting, it's hard to hold this at my age, you know. The problem with apraxia is that there in your brain, in the parietal cortex, you have motor movements, small motor movements programmed to make a bigger motor movement. So you can think about it. If you had a robot with an arm that had all the muscles we have and the joints we have, it would take quite a few lines of computer code to throw a baseball like that. Well, the same thing is true when you do this. So when people have apraxia, they can't make these individual fingers work together to produce the proper motor movement. So you see them kind of struggling like that. And that is apraxia. It's making small motor movements into a bigger, more complex movement correctly. And that would be a pretty typical clue of cortical basal syndrome. And if you, like in my exam, often I might not be thinking about it, but when I see that, the next thing I do is have that person imitate hand signs. So I say, do that, and the normal person does that with about 100 millisecond interval. But people that have apraxia, when you say do that, they're kind of struggling to make those finger movements work appropriately. So that would be cortical basal syndrome. So we've got drug-induced, age-induced, progressive supranuclear palsy and all the variants, multiple system atrophy, and then cortical basal syndrome.
Okay, great. And there was also a question about drug-induced Parkinson's. Could you maybe elaborate on what that is, what that means, drug-induced Parkinson's, and what might lead to that?
Well, if you did something negative to dopamine receptors in the brain, which would be that's the system, the nigrostriatal system that releases dopamine to stimulate dopamine receptors. If you block those with a medication, then that would produce something similar to Parkinsonism as well, too.
Okay, thank you. And maybe this one will go to Dr. Fleisher. There were a lot of questions about nutrition and diet. So we do know that there are people who want to know more about the gut-brain connection, especially in regards to any sort of vitamins, supplements that could be helpful for people with Parkinson's. And also, if you could speak to the effects of alcohol. How does alcohol really affect people with Parkinson's?
Sure. So it's a great question. And I'm lucky I get to work with a dietitian who really focuses on Parkinson's. And so I think a couple of different things. Number one, right now, there have been many, many, many vitamins and supplements that have been studied rigorously, and none have been shown that they are treating or curing or slowing Parkinson's. So if you are taking something because someone or the interwebs or the TV or a family member has sent you an article, unless you are deficient in a vitamin, then you don't really need it, right? So for most people, a single daily multivitamin is going to have enough, because if your kidneys are functioning and your liver is functioning, you are going to pee out or discard in other ways what you don't need. So for a lot of people, they're taking many, many vitamins and supplements, and that is successful in producing very expensive urine and really doing very little else, okay? So we should be getting our nutrients and our vitamins and minerals through diet. A lot of people will ask, what is the best diet for Parkinson's? I think so far the most compelling scientific evidence that's out there is something called the MIND diet, which is a mashup of the Mediterranean diet and something called the DASH diet. And it is kind of what you might imagine. And if you think about what would be a healthy diet, it's lots of lean protein, fruits, vegetables, whole grains, so less processed stuff. Red wine is okay on that, but not in excess. So thinking about bridging to the alcohol question, I have some folks that will cut out everything upon diagnosis of Parkinson's. And I think, like everything, we need to balance quality of life. And so do we advise that people are going out on a bender? Absolutely not. Alcohol can lower blood pressure. So if you are someone who has a drop in blood pressure, the same amount of beer or wine may hit you a lot harder than it used to. So being really mindful and moderate. If you're starting new medications, asking your physician, is this okay? Is this safe? But I don't think that there is a blanket, absolutely not. There's also not a blanket, you must be drinking red wine if you have Parkinson's, okay? So similar to if smoking seems to be related to preventing, does that mean everyone should be smoking? No. And it does not mean that everyone needs to be drinking red wine, although saying that in California, I feel like maybe is not allowed.
All right. And since you brought up smoking, there's a question about marijuana use, if that would slow the progression of Parkinson's.
Yeah, I know of no evidence for that, and that would be common knowledge if marijuana did anything good. And there's a paper published in the journal Neurology, I don't know, about 5 years ago, and they looked at all the studies that have related to marijuana and treating neurologic symptoms, and helps a nickel's worth in terms of there's a clinically significant effect, but probably not a clinically important effect in terms of spasticity in people with MS. And of course, there are these babies with Lennox-Gastaut syndrome, which is an infantile seizure disorder, among other things. And these poor little babies have, 50 seizures a day. And so that's where CBD is actually very helpful in reducing the seizure numbers, and in fact, enough so that the FDA has approved a medicine for that. But, I was in the Army, I was in college, I've had a lot of good times, but when I decided to work beyond retirement, I don't think booze is a good idea in any amount, and I don't think that marijuana or any other drugs like that are a wise idea.
Okay, thank you. There were a fair number of questions about sleep. As we know, sleep is kind of the new frontier, and in medicine, I kind of feel like there's more and more research about sleep. What could either of you tell us about the REM sleep disorder, and are there any over the counter or certain medicines that are helpful for sleep in Parkinson's? How about, there was a question about melatonin use. There were questions about environmental changes that could be made at night to promote better sleep. If you could maybe elaborate on that.
Sure, I think absolutely. So starting with sleep hygiene, which really has to do with, are you, going straight all day long, lights are on, screens are on, and then you're just expecting that your brain is going to click off like a switch and you're going to fall asleep? Because that's not how our brains work. So having a regular daily schedule where you are sleeping at night and awake during the day. Parkinson's has a tendency to want to shift people's schedules. And so we see sometimes people staying up later and later and sleeping later and later. Go with the sun, use those natural cues as it's getting closer to bedtime, winding down, turning screens off, doing more relaxing things to help prepare your brain. So we know that, there are various different chemicals in the brain that kind of give you the signals of when it's time to go to sleep. And melatonin is one of those that's part of setting your circadian rhythm. So everyone's brain makes melatonin. People with Parkinson's, we've seen from various studies that the melatonin levels are different, right? So melatonin is available over the counter, and similar to the way that we replace dopamine with levodopa, for some people, we need to replace their melatonin with external melatonin. The challenge is there are a lot of different formulations. It is a supplement, so there's very limited regulation. And what becomes challenging is if people have trouble falling asleep, most of the melatonin that you can find is immediate release. So if you go to CVS or Walgreens, and if it's chewable or dissolvable or fast acting, it means it's going to kick in quickly. It will help you fall asleep, but it won't necessarily help for people who have trouble staying asleep. And what's interesting is that REM behavior disorder tends to happen later in the evening. So melatonin can be very effective for treating REM behavior disorder. But what I hear from people so often is, I tried melatonin, it didn't work. And it's often because we're taking the immediate release, fast acting, and that wears off after a few hours. And after a few hours is when the REM behavior disorder kicks in. So talking with your healthcare provider about, there are some time release formulations out there, and those can be very helpful in folks where they've tried it and said, I don't think this is helpful. There are other medications that we can use too. The better people sleep, the better their mobility the next day. So we do want to really focus on sleep.
Said. All right. So Dr. Ahlskog, do you know of any studies out there that have looked at the effects of COVID-19 on Parkinson's patients and how COVID-19 may have affected people with Parkinson's? We hear about long COVID symptoms, and is there any recent literature on that?
Well, I have a vague recollection that the answer to that is no, but long COVID, actually, that's, it's a different problem, but that's not all that rare. And this is where you get like a chronic fatigue fibromyalgia syndrome, which is common in the human populace, and that just goes on forever. And I know people, there are reports that it persists for at least a year after the COVID infection, and exactly how to treat it is totally unknown. And these are people I don't want to see in my clinic because I can't help them. I mean, if I see them, I do my best, but I'm not smart enough to know how to treat that. And you hope that after a year it gets better, but I don't know of anything that really reliably tells us what's going on after a year of long COVID. Anything to add to that?
No, I haven't seen anything in terms of the interaction between long COVID and Parkinson's. I will say that, anytime that someone with Parkinson's has a cold, has a virus, it is very common that the Parkinson's symptoms worsen. And, we get a lot of frantic calls. I think the thing to keep in mind is you should return back towards your baseline after you get over COVID, after you get over the flu, but it may take much longer than someone who doesn't have Parkinson's. So that sort of gradual, having patience and getting back to the therapies, making sure you're staying on your medication regimen while you're sick, and avoiding over-the-counter cold medicines. There are a lot of over-the-counter cold medicines that have DM added to them. That is an anticholinergic medicine, and that can actually increase confusion, hallucinations, constipation. So that is your Tylenol PM, Advil PM, anything that basically says severe max flu plus usually means it has something added to it, and those are not safe for people with Parkinson's.
Okay. There were a number of questions about exercise. What type of exercise is best and how often, how frequently? What kind of exercise programs would you recommend for Parkinson's?
Well, that slide that I put up, it was just one slide, but it focused on regular aerobic exercise. So that's exercise that makes you fit, defined as a VO2 max. That's a parameter of whether you are physically fit. And that's the exercise where the science is. So actually, I read those papers that I told you about, starting out with 7,000 entries in the search engine for published medical journal articles. But I was careful to distinguish aerobic exercise from some stuff that's called exercise, such as I know in some nursing homes, you do exercises like we just saw. Well, I'm in favor of that because, stretching and toning, who would argue it's not good for you, but that's not aerobic exercise. So the science is with aerobic exercise. And you can't do a randomized control trial on this because you would have to take a group of people who are over the age of, choose an age, 60, and then randomize half of them to where they engage in regular aerobic exercise. Well, that group's going to say, man, this is really pretty tough to do this. I'm getting hot and sweaty, the intention. And so they decide not to do it. And then the other half is going to say, there's a reason for doing aerobic exercise. I think I better start doing that. And that's a control group. And then these exercises would have to be continued for at least a couple of years because this isn't the kind of thing that you start doing and all of a sudden you wake up one morning, you feel like you're 20 again. Well, things don't work that way. So aerobic exercise you have to take on faith, but having read that literature on that, and I still collect articles that look at aerobic exercise and a number of things like brain aging and so on, incidence of mild cognitive impairment, and things come up pretty consistent. And there's a lot of science behind that as well, too. For example, there are things that can be liberated into the brain, like glial-derived neurotrophic factor, brain-derived neurotrophic factor, and these are measurable biochemicals that when they're in the brain, they help stimulate synaptogenesis and maintaining the integrity of the brain, and those kinds of things have been measured, and it's pretty clear that, plus things that facilitate forming new synapses, synaptogenesis. All of those things are well documented in the literature.
Mm-hmm. Okay. We had a question about portable neuromodulator stimulation. Would either of you want to tackle that one? Portable neuromodulation stimulators.
I'm not sure exactly which device this is referring to. I think there are several different things that are out there that people have used. They're sort of variations of direct current and transcranial magnetic stimulation. There are things that have been tested in sort of rigorous scientific ways. And then there are versions of those that have been sort of pared down and made accessible commercially. I am not aware of any evidence that shows that those are helpful. Have you seen?
I have no knowledge of this topic.
Okay. All right. There we have it. All right. Would one of you care to comment on the genetics behind Parkinson's? We know about younger people, and you spoke to younger people with Parkinson's in terms of a genetic component. What general knowledge should we know about the genetics behind Parkinson's? And do family members or should family members talk to their children, or do they need to have other family members concerned about this?
I'll start with the latter point first, because you worry about your kids coming down with things, especially if you think you've passed that on to them. So if you think about data that's published from Olmsted County, Minnesota, where they looked at that. What's the risk if you have one immediate family member with Parkinson's disease? Well, you have to start out, what's the female risk? What's a lifetime risk for coming down with Parkinson's disease just in general? Well, for females, it's 1.3% lifetime risk of coming down with Parkinson's disease. For males, it's 2%. If you have an immediate family member, that changes by threefold. Well, 1.3 is 4%, and 2% times 3 is 6%. So even if you've got one, it's one family member, you really haven't changed that substantially because you're still in a small minority. And when it gets down to medical genetics in general, I don't very often suggest ordering genetic testing, because if you have a positive test, it doesn't modify how you treat it. But it's certainly it's more relevant to certain ethnic groups like Ashkenazi Jewish people. There's the alpha-synuclein gene, this risk factor Gaucher's gene. If you have one of the two genes being positive, that increases the risk. And for alpha-synuclein, I'm sorry, LRRK2, that's a different gene. Then that increases your risk, and it's incomplete penetrance, but most people get it, something like 80% penetrance. So I started mentioning about the alpha-synuclein gene. That's in people that have primarily Italian or Greek heritage, and that's where alpha-synuclein came from. There was an article in Science by Polymeropoulos in 1999. Big Italian family that Larry Golby, who was a neurologist at Rutgers, had followed this family. He practiced in New Jersey. He started to see people that have family histories of Parkinson's disease, and there was Italian ethnicity continuous with that. And so he went to Italy and followed up this family named Contursi, the Contursi kindred, and it turned out there was a dominantly inherited gene, and that's where alpha-synuclein came from when that was reported by Polymeropoulos in Science back in 1999. And it turned out that that's actually not a very common gene, but in those families, it's dominantly inherited, so it passes along. But in general, I don't order genetic studies because it doesn't really help me help anybody. But I respect if people want to know. I'll order genetic testing, and that's about all I can say about that.
I agree with Dr. Ahlskog, and I think just something that we consider, I think I may order genetic testing a little bit more, or especially in folks who have earlier onset Parkinson's, so age 50 or younger. But I think one of the really interesting things that we've seen change, particularly in the last 10 to 15 years, even when I was in fellowship, we really were not doing a lot of genetic testing at all. And part of that was we didn't have as many genes then that we know about now. And to test for genetics could be $10,000. Now, because people have really been studying this tremendously, the cost of genetic testing has gone down tremendously, and the number of genes that have been recognized has really increased. And so the Contursi, the kindred that was mentioned, where alpha-synuclein was discovered, that's a gene where if you have that gene, you're very likely to get Parkinson's. What we know is that there are a number of genes, and probably most of the genes that we will learn are not a guarantee that if you have this mutation, you get Parkinson's, but it's more that there's a combination of many, many, many genes. And if you have a mutation, it increases your risk just slightly, not enough on its own, but almost like we're all sort of a combination lock. And if each of those different genes is lined up in just the right way, that could lead to Parkinson's, which may be part of why everyone's is so different. What's really interesting is the more that we have been looking at this and trying to identify things like that LRRK2 gene or the GBA gene, there are pharmaceutical companies, there are researchers who are looking at this to say, okay, not everyone with Parkinson's is this going to apply to. But if this gene is related to the cause of this person's Parkinson's, and I can study that pathway and come up with a treatment that might work for that pathway, well, then that might help that segment of people with Parkinson's. And while that feels very tiny and itty-bitty steps, that to a large extent is actually how the field of cancer has changed tremendously, I think. So I think, 50 years ago, people just had cancer. right? And we didn't differentiate. We didn't know what organ it came from, let alone have different genetic markers and different receptors. And now if you listen to commercials, right, if you have this positive, this negative, something, something, something type of cancer, this treatment is for you. The way that they got there was sort of the way that Parkinson's has started to go. So it's getting a bit more personalized and precise.
Thank you for reminding me about young onset Parkinson's disease. So that term is defined as Parkinson's disease onset before age 40, and that behaves like a horse of a different color than the usual Parkinson's disease onset. In Owen County, Minnesota, it's less than 1% of the whole Parkinsonism population. And people that have young onset, there's a more than trivial likelihood of having this Parkin gene, which is not a Lewy body disorder, and it behaves entirely differently. So if you think somebody has that, I think that's worthwhile ordering, because they have a different course, a more benign course, more frequent dyskinesias, more frequent fluctuations that occur early on. But I think they can be reassured that this is not Lewy body disease. There are a couple of other genes that nobody ever sees, DJ1 and PINK1, and those would be in the genetic panel that you'd order for that.
Okay. Now, I know both of you have been highly involved in research. How would you advise people that might be interested in participating in a study? How would you advise people that have an interest in signing up to participate in research? How would you go about advising people, and what are the biggest studies out there? And could you give some guidance to this population?
I guess that's me now.
Either one of you.
Well, I was very enthusiastic about clinical trials and participated in some of those, but the big ones that I showed you, there are 15 different clinical trials since that DataTop trial in 1988, and they've all been negative. And we just don't know enough about Alzheimer's disease, Parkinson's disease, PSP. I could go on and on, all these neurodegenerative diseases, and pretty much it's a crapshoot. So if you would recognize that, I think that's wonderful to sign up for that, because we need to get answers. But pretty much what's happened to this point in time is we're just crossing things off the list. But what I've noticed in the clinical trials that I was involved in, this is some years ago, is that I think they really benefit from seeing, you have scheduled appointments with a Parkinson's specialist, and you see them routinely then, and you get a lot of benefit just on routine care as well too. So I think that's a clear benefit.
I think thinking about the practicality of, I want to get involved, I don't know how to get involved, what do I do to start? Speaking with your Parkinson's neurologist, speaking with whoever is providing that care is a great place to start. But there are also a large number of various different clinical trial directories and places where, Michael J. Fox Foundation, for example, has a database where you can sort of share information about yourself. And if there's a trial, or if there's a study, right? So there are clinical trials certainly to try different medications, but survey studies, things where we can just learn more about Parkinson's, they will contact you, for example. So there are a lot of different ways to enroll. Clinicaltrials.gov is run by the government. You can look up what various different studies are in your area. So I think that is a really powerful way to get involved, and a way to sort of change things. Even if it doesn't change it for you directly, it may give knowledge for future generations as well.
Okay, and I think the last question or category, I really want to appreciate caregivers out there. I think many times they're so underappreciated, and there were questions about what do caregivers do to really get more support in communities, and how do they go about seeking help? And maybe Dr. Fleisher, you could answer this one. What do they do when they're struggling and need additional assistance?
I think reaching out, and it can start with your doctor, your healthcare providers. If there is a social worker associated with your care that you're receiving or your loved one is receiving. I was just telling someone, but I'm married into a family of social workers. I fully believe that they are sort of out there saving the world. They often know what the various different community resources are and can point you in the right direction. If you don't have a social worker, connect with your community, right? Connect with a social group or support group. Ask around for what people have tapped into. Some of the best little life hacks and gadgets and things that I know to recommend to my patients and families have all come from care partners sharing with each other. So I think start wherever you are, but there is always something. Go online, look at the bigger groups, look at the bigger foundations, watch the videos, ask around.
I'm going to add to that too, because I see a lot of caregivers and these, mild cognitive impairments, sometimes more substantial. And these are the heroes and heroines of our society. I mean, tears come to my eyes sometimes when I see these wonderful, spouses. They've lived together for 40 years and now they're total care. And at least in my clinic, boy, I just see a lot of wonderful human beings as caregivers, and those are God's blessings and they're going to be blessed for what they do.
Yes. Amen. That's right. Well, thank you so much for being with us today. We've just really appreciated all your knowledge and experience and just imparting all of this wisdom to us here in the Santa Barbara area. We just really thank you for being here.